right? So there it is, right? And they're going to form antibodies against what they don't have, right? And that is my RBCs, right? So what blood products are compatible with them? Well, first of all, the same blood product is always compatible, right? You can always give someone what they are, right? Your type A blood, you can give type A blood, right? But what else is compatible? What else can you give someone who has type A blood? Can you give B blood? No, because B blood has B antigen, and what do we have? We have anti-B, right? You're going to what? What's the fancy word? You're going to agglutinate, right? You're going to have a transfusion reaction. What if I give AB blood? Can I give AB blood to someone with type A blood? No, because that AB cells, right? On the cells right here, I give this guy up there. What's going to happen? The B is going to attack it, right? Because there's B antigen there. So what's compatible is its own thing, A, and O, because O has no antigens. There's no antigens there for it to attack. Okay, so type A blood is compatible with A and O. Yes, you could memorize this, right? But that's you're gonna get confused. Like, was it A, B, A, O, A, O? You're gonna have crazy mnemonics to try to figure it out. But you try to walk through it every time. Okay, so the same thing for B blood, same thing for what, C blood? No, AB blood, same thing for O blood, right? So universal donor is who again? O negative. And that's only 45% of our population, unfortunately. So that's so it's a high commodity to get blood products. Okay, so for compatibility, the Rh factor, that's just negative and positive, right? So do you have it or not? And as a rule, we don't give what to what, right? We don't want to play around and find out, right? We don't want to say, oh, I'm going to give you positive or negative. It doesn't matter, because someone with not the rhesus factor could have anti-rhesus factor. We don't know, right? We don't know if they've been exposed before. It's like, well, they're a man. They didn't have birth, right? So, but what else can men do? They can have sex with other men, right? They can have blood bonds as a 5-year-old. So you can cut their hand. You've seen every movie and from the 80s, right? When they get blood bonds, right? They could have had a cut and exposed to their friend. There's all kinds of things that could have happened that they could have been exposed to blood. Okay, so we don't find out. We're going to make sure we don't give positive, negative, or negative to positive.
Don't give positive.
Good. You don't give a cell that has it positive to someone that is negative, because that person that's negative could have the antibody against it, right? Because you form antibodies against what you don't have. Can you give negative to positive?
Yes.
Yes or no? Yes, because negative does not have it, right? So you give it to someone that is positive. Someone that's positive is not going to have the antibody against it. That doesn't make sense because they have it, right? So there's no antibody to attack it, right? So you have to think of where the antibodies are at and where the antigens are at. That's going to get you very far. And remember, when you're giving RBCs, you're not giving all the blood. You're not giving the plasma. All you're doing is giving the cells that have the antigens on it, right? So for PRBCs, it's the same type. That's always going to be the right answer, the same type. Or something that has what? Does not have the antibodies the person has, is a way you can phrase it, right? So the type without the antigen to the type, right? So if you have a cell, if you're giving RBC to someone, you want to make sure that the donor cells, right? You think of the donor cells, oh, those are the antigens I'm giving. And what antibodies does my patient have? Are they going to attack it or not, right? Right, remember, you're giving cells, not plasma. Okay, so another wrinkle here is FFP and platelets. Right, so that was RBCs. What about FFP and platelets? With FFP, what are you giving? You're giving fresh frozen plasma. You're giving antibodies in a bag to somebody. Right, so you got to think of, well, shoot, what cells do they have? Right, if they have A cells, I'm giving plasma that has anti-A. That's not good. What plasma has anti-A? B blood, right? So that's type B FFP. Type B FFP has anti-A in it. I cannot give anti-A to cells that have the A antigen. Okay, so you're going to make sure you're thinking about what am I giving to the patient? I'm giving them antibodies, or I'm giving them antigens, right? Or which are cells, right?
So if you're giving plasma to someone who's O, they would have to receive plasma from
Good. So someone that's O negative, they have you're asking your O negative blood, right? So they're given O negative blood. You want to make sure. I mean, really, they're now the universal recipient because you can give that for FFP. They can take anything, right? Because they have no cell antigens. So you give them whatever FFP you want. But when we go back to thinking, switch gears back to RBCs, when you give O negative when you're giving what kind of blood is compatible with O negative blood? Only O. It's kind of that's not a cool deal, right? They're the universal donor, but when you have to give cells to them, right? Because O negative blood has the antibodies against everything in their bloodstream itself, right? So can you give them A blood? No, because they're going to attack it, right? Because they have the antibodies. They have all the antibodies. So that's a crap deal. It's like, well, shoot, they could give it to everybody else, but they can only accept it from their friends, only accept from other O patients. Okay, so O negative can only supply O negative. That's it, right? AB positive they can accept, from everybody. But what kind of FFP can they take?
O negative. I mean, they can take everything, right?
Well, if you give O negative blood to someone, O negative FFP to someone that's AB positive, O negative FFP has all the antibodies, right? And you give all those antibodies, anti-A, anti-B, anti-RH, to someone that's AB positive, it's going to attack the A, it's going to attack the B, it's going to attack the RH, right? So AB positive is no longer a universal recipient of FFP. It's only going to be what? AB positive FFP.
So RH negative, they have the antibodies for RH?
So RH negative, they could have the antibody. We don't know what kind of activities they've done, pregnancy or otherwise, right? So if they have the RH factor or not is dependent on whether they got exposed to it. But we're not going to play around. We're going to make sure that we don't expose them if we can. Okay, so that's FFP. What about platelets? Platelets do not care. You can do whatever you want with platelets. You can give it to anybody you want. Platelets don't have antigens. So what are platelets? The platelets, when you're making platelets in the bone marrow, all it is a huge, like Starship Troopers kind of alien insect. It's like kind of just growing like huge right there, and it's kind of leaking into the bloodstream. And it's kind of like when you pull off the yellow socks off someone and it flakes. That's all it is. Those are just flakes of a huge platelet monster cell. That's all it is. And those little flakes don't have antigens, unfortunately. Or fortunately, I don't know. All right, so that's all it is. It's just little platelets are just like fancy flakes. That's a cat food, isn't it? Fancy feast. Anyways, we have platelets, right? So platelets you can give platelets to whoever you want, okay? Because they have no antigens, right? So I'm giving platelets to somebody. What blood type are they? Doesn't matter. You're still going to check it. You're still going to go through the process, but you're giving somebody that's not going to have a transfusion reaction. Okay, so when you give an antigen to somebody, right, you want to make sure that there's no antibodies against it, right? That's the Sentinelese Indians, and like off the coast of India, there's a little island there that has been touched in like 200 years, and they are cannibals. And if you get close to them, they're going to attack you. They're going to, if you have, they say that you're not of their type, right? They're going to form antibodies against what you are not, right? So this guy wanted to find out, right? So he went there. He's like, you know what? I'm going to spread the word. I'm going there, and this is what's going to happen. And yeah, he got killed. So that's the you don't if you don't give antigens to someone that has the antibodies is the moral of the story.
Did he get eaten?
I don't know what they. I'm not kind of what they did a little sous vide. I don't know what they. No, yeah, he got. They threw his arrows at him, and he still got close. Like, I mean, I can talk them out of this. I got this. Right? He arrived and did not leave.
So from here on out, O negative people would be referred to as smooth bloods.
Smooth bloods.
Yeah,
Smooth-brained. Bumpies and smoothies.
Yeah.
Okay. All right. So that is compatibility. Okay.
Mud blood.
Mud blood. Mud blood has another meaning now.
Yeah.
All right, so PRBCs. All right, so going back a step. So PRBCs, again, you want to keep the hemoglobin greater than 7. What's a normal hemoglobin? 15. But we're going to let it get all the way down to 7 before we start transfusing. It's like, why are you going to wait so long? Well, because there are transfusion reactions, which are the last part of our lecture, is there's reactions that can happen to the patient, and they are life-threatening. Right? There can be clerical errors. People mess up. It happens very rarely, but it does happen. And you don't want to get put into that situation. right? The exception is, of course, if you have you're actively bleeding in the room. Like, no, let's wait to 7, right? It's not, you're not going to get that change right away. Okay, takes a second. And with a heart disease and with stroke, sometimes they say greater than 10. I think it's greater than 8 now. I think they've kind of lowered that threshold. Sometimes greater than 9. All right. But you want to make sure that it's, you don't want to have low oxygen to your brain. You don't want to have low oxygen to your heart when someone's having an active heart attack. Okay. So every unit raises your hemoglobin by about 1 gram. So if you give someone is 6.5 and you give them 1 unit of blood, it should go up to 7.5. Best case scenario, maybe 8, right? But it's only go up about 1 gram, right? And then you're like, well, shoot, their hemoglobin's 5. I'm gonna give them 3 grams. So that's gonna go 7 or 6, 7, right? And 8. So that way they'll give them a little leeway. You don't give more than 1 product at a time. That's not good practice, right? Because it can cause, A, it can cause transfusion reactions, but also B, it's about 350 cc's per bag, right? So you have to be extremely careful with someone that is CHF or renal disease, right? That's at risk for fluid volume overload, because that's going to be a lot of volume that you give into the patient. Between bags, you give like a diuretic. So we're going to give 1 bag, give a diuretic to push off some fluid, that we can give it more RBCs the next time around. All right? And we have to make sure we're not getting unnecessary. We're going to make sure they are symptomatic, right? So their hemoglobin's, is more than 7. Really, you have to say, well, are they symptomatic or not? Sometimes, especially like in the ICU, when you have patients that are hovering around like 7.2, 6.9, 7.3, 6.8, it's like hovering there. You got to look, so well, are they bleeding? And do we need to really, transfuse or not? Or can we hold off until it actually trends down? Because when you get a hemoglobin result, it's off by like 0.5. So you get a hemoglobin of 7, it could be 6.5, it could be 7.5. It's anywhere in between. Okay, so we gotta be judicious, because when we give RBCs, we could have a transfusion reaction. We don't want to put the patient through that. That could be even worse. Okay, and then what else? So are they actively bleeding? This always supersedes the 7 rule. If they are bleeding, you're going to give blood. Okay, and then dropping hemoglobin again can be due to IV fluids they got in the ER. Those 3 liters of saline can dilute out their blood. And PRBCs are treated, so that means they are processed at the Red Cross, and they are they're tested to make sure there's no like HIV, there's no Hep B, there's no Hep C, there's no infection of the blood product you're going to give them. So they also do what's called leukoreduction. They take out the white blood cells, right? They remove white blood cells from the RBC they're giving them, because white blood cells can harbor a virus, and that virus is cytomegalovirus, or CMV, right? So it prevents a CMV infection, which will cause a fever and such, right? So so they give leukoreduced PRBCs. You'll see that when you give a blood product, it says leukoreduced. Okay. What else? They're also washed and irradiated. That's a possibility, especially for like cancer patients. We're going to take away all the things. All we want is pure RBC. It's like nuking in the microwave, like the broccoli in the math problem, right? You're going to nuke it, and you're going to prevent any kind of infection that might be there, or virus that might be there. We're going to just give the RBC. Because otherwise it's an acceptable risk. It might have some other stuff in it, but we're not going to have anything go wrong by doing a lot of irradiation. Washed means they put it through a little tumbler, and they wash the RBCs a little more. Okay, and you just give just the cells. So you mentioned preservatives. What are the preservatives for? Yeah, you want to give smooth blood to a smooth blood patient, right? So you want to make sure that it is blood that is not a clot, right? You want to make sure that is not a whole clot you're giving to the patient. You want to make sure that it is actual blood that's running, that's going to get to the patient, not cause issues, right? So we put a preservative in it to stop the coag cascade, right? The coag cascade has calcium at many, many steps, like 8 out of the 12 steps. There's calcium involved. So if we bind all the calcium, they're not going to clot, okay? So EDTA is an example of a preservative. And then, that being said, if we give like 3 products to a patient, you're going to really, really start lowering their calcium level. So we want to check their calcium levels after every 4 units is good practice. Every 4 units to prevent hypocalcemia. All right. The other thing that can happen is if you give cells that rupture, what are inside of every living cell? What electrolyte? potassium, right? So if a cell ruptures, the potassium can leak into the bloodstream. So you want to make sure the cells are not going to rupture. And what makes cells rupture is when they're old, right? Another fancy word for old is senescent. So when we have senescent cells, we have old cells or expired cells. That's not something you give to a patient. So on the label here, we check to see, is it expired, right? Do we have expired blood products? If you're giving expired blood products to a patient, they have the risk of those cells just rupturing on arrival, right? It's like when you buy old lettuce and you're like, oh, this is not functional, right? So it's going to be, it can, what's the word? It can rupture and it can, or hemolyze, and that can then cause a hyperkalemia because there's potassium in those cells. The other way you can damage the cells on the way in is have too small of a gauge of needle, right? Or too small a gauge of a catheter. So to make sure that the catheter size is adequate so the RBC gets in and it's not going to hemolyze on the way in. Okay, so usually they recommend like a 22 gauge or higher, right? Usually they do 20 gauge to be comfortable. So 22 gauge is acceptable. That's like the exception. So 20 gauge or higher or lower. What is it? Or it's bigger, right? So 18 gauge is bigger than a 20 gauge. 16 gauge is bigger than a 18 gauge. So 20 gauge or bigger. Okay, not higher number because that's confusing. All right. Anyways, so unit compatibility. So we've been talking about this a lot. So this should make sense. Universal donors O negative because O negative blood has what? You're giving RBCs to everybody, right? So it's universal donor because it's donating just the RBC, which has no antigens on it. Has no O, sorry, has no A, no B, and no RH on it. So it's compatible with everything. Okay, so it can be given to any blood type. In emergency, we can give it, we give O negative blood, right? Because we don't know if someone comes in a car accident, they come to the hospital, they're not going to send the blood down to lab and let them do all those sign experiments, and they call back 20 minutes later, oh yeah, they're AB positive, right? They're not going to do, we're just give O negative immediately, right? There's a little fridge right there in the ER when they come in. It's like, oh, pop from the fridge, let's give the O negative blood, okay? So then what else? So again, O negative has all the antibodies, so you can't give them, they can only accept their friends, right? Anyways, universal recipient is AB positive. They have no antibodies. They're not going to attack anything. Right? If they're AB positive, they're AB and positive, or RH factor, and they're going to form antibodies against what you don't have, and they have everything. So they're not going to do that. So you can give them what? Anybody, because they don't have antibodies against anybody. They can take anybody's cells, right? So you can fill out this table here. So that will make sense, right? On A, B, and O. This table right here looks at more negative stuff and some other rules. O can transfer to anybody. AB positive can take anybody, right? And I mean, these rules make sense, but if you can get to it every time, you're going to be a lot better. Your pathway right now to the right answer might be very wooded with a machete and some large equipment, but that you can't take narcotics with. That you want to be able to, you want to try to get this pathway more ingrained, right? So you need to go up to a whiteboard and teach your friends, like, okay, we're going to go over blood products, and just say, let's do A, and then your friend goes up and does B. Your other friend goes up and does AB. Right? If you have more than 3 friends, that's cool, right? Good for you, right? But otherwise, you don't want to get your study group to be way too big, right? So, but if you have a 4th friend, sure, they can do O blood, right? And you can go through it. That's about O negative. What about O positive? And the first person can do A positive and A negative. The other one can do B positive, B negative, right? So platelets, all right? So platelets have no antigens. So when we're giving it to someone, don't care, right? Ideally, we're going to give the same type, right? But we really don't care, right? So the goal with platelets is to restore platelets. And why would you need to restore platelets? Because they're bleeding, right? Why are they bleeding? It could be because of trauma or because they got anticoagulants and they're bleeding. So something's going on that they are bleeding, or that their platelets are low. And your platelets can get low because of, again, anticoagulants we're giving. So we make sure we hold anticoagulants when platelets are low before they get too low, right? So less than 100,000 platelets, we're stopping anticoagulants. We're not going to give any more aspirin, any more heparin, any more prophylactic things, any more apixaban, 10A inhibitors, warfarin. We're stopping it at less than 100K. Sometimes they'll let it, like maybe the risks outweigh the benefits. They'll say 75K, okay. But it's like keeps going down to 60K and 55K. It's like, oh, yeah, that's enough. We'll stop now, okay? but definitely less than 50K, that's actually when you start transfusing platelets. And the caveat there is when bleeding, right? If you're not bleeding and your platelets are low, we really are going to drop the number as low as we can. We're going to say, because platelets are kind of hard to come by, because platelets are in a very, very small amount compared to RBCs and plasma. So to get someone's platelets, right, to give platelets to somebody, you have to pool it from 4 to 6 friends, right? So it's a real party. You're going to have to get 6 friends together, get all, and they have to give blood. 350 cc's for each one of them has to give blood, and then it goes to a blood bank, and they're going to pool those 6 people's platelets together, and then give that to you, right? So it's a whole cumulative or community event to get someone's platelets. Okay, so we lower that platelet count all the way down to like less than 10K even. So if your platelet count is less than 10K and you're not bleeding, no matter what, we're going to transfuse. If you're bleeding, though, we're going to say, okay, if you're less than 50K and bleeding, we're giving you platelets. But if it's 25K and you're not bleeding, we're not going to give you platelets. If it's 15K, we're not going to give you platelets unless you are bleeding, right? If it's 5K, what are we doing? No matter what, right? So less than 10K, no matter what. And that number keeps changing. It used to be 30K when I was in school, and it was 20K 5 years later, and now it's 10K. So it keeps dropping and dropping and dropping. All right, so if you're actively bleeding, make the platelets more than 50,000. What's a normal platelet count? Normal platelet count is about 250-ish, right? 250,000. Okay, 150 we're getting concerned. Sometimes some labs say less than 100, less than 200, but 250 is the normal. What is too much? What is thrombocytosis? Too much platelets. What is a too high platelet count? Greater than 400, greater than 500, but like what number is too high?
Greater than 400?
Yeah, but we'll tolerate 500K, we'll tolerate 600K. Right, so I always do this joke and nobody gets it because everybody's new nowadays. But there's a movie that came out in the late 90s, right, with a pinky, right? So 1 million, right? So greater than 1 million is concerning, but we're not going to, like with polycythemia with RBCs, we're concerned when it's more than like 48, 50 hematocrit, right? But with platelets, we don't really care until it gets more than 1 million. Okay, all right. Each unit will raise your platelet count about 30,000. So if platelet count's 40,000, it's going to raise it to 70,000. Okay. And then when you have a cold patient, that's not good because the platelets are not going to work. Right? Someone's bleeding, you don't want them to be cold. So there's this triad known as the deadly triad for patients that are at risk for bleeding. One of those things is being cold. Right? Being cold makes it so our platelets don't work. And if you're bleeding, you want platelets that work. Right? You want them to do the clotting. And then the thing is coagulopathy. That means that you used all your clotting factors. That's going to make you bleed more. Okay. And then acidosis. When we talk about acidosis, denatures things. It's going to denature the clotting enzymes and all those factors. So you don't want acidosis as well. So those are the 3 things that we want to avoid when someone's bleeding. All right. So massive transfusions are usually where you're going to see platelets given as well. It's like no matter what, and usually it's given in like a 1-to-1-to-1 ratio. So we give 1 PRBC, 1 platelet, and then 1 FFP, which is the next slide. Okay, there's no incompatibility because there's no antigens, and it's pooled for about 4 to 6 recipients. Okay, so that's the deal with platelets. Okay, then we got fresh frozen plasma, so FFP. So with FFP, it is plasma. You're just giving whole plasma to somebody. So plasma has albumin in it, it has clotting factors in it, it has platelets, it has antibodies in it, and it has fluid in it, right? So those are the things that fresh frozen plasma has. And usually you're giving it for a INR, right? INR is a measurement of your ability to coagulate, right? So you're going to give clotting factors to someone for that reason. Okay, if it's like an anticoagulant, we know anticoagulants specifically block specific clotting factors, and usually we give a derivative of FFP. We take the FFP in the lab and we then filter out just the clotting factors, and that's what prothrombin complex concentrate is. It's just a concentrate of prothrombin, which is part of the clotting cascade, and your factors that you need to make clots, right? So But otherwise, if you're just giving FFP to someone, it's usually because their INR is greater than 1.8, right? Greater than 2 is concerning for coagulopathy. So if it's less than 1.8, are we giving FFP? If it's less than? No, right? So less than 1.8 is not, you're not going to do it because the INR of the FFP itself is like 1.5, 1.7, 1.3 on a good day. But you often have docs that say, hey, give FFP until the INR is less than 1.3. That's not how diffusion works, right? Things go from high to low. I can't go from medium to medium. It's not gonna work. I'm not gonna be able to drop that. It's gonna be an impossibility. Okay, you're just putting the patient more at risk for transfusion reactions when you do that. But if your INR is 3 inside the patient, and I give an FFP whose INR is 1.5, well, yeah, that's gonna by diffusion, it's going to fix it, right? So usually we try to find reversals if we have them, right? So what are reversal agents for dabigatran, for instance? This is also Monday, but that's cool. That's part of PTSD. So what are your reversals for dabigatran, right? That's a specific coag factor inhibitor. It's a direct oral anticoagulant. Starts with an I. It's also a MAB. It's idarucizumab, right? And then we have like your 10A inhibitors. What's your 10A inhibitor reversal agent? Costs $50K. And Dexanet, right? What about heparin? Protamine. What about warfarin? PCC. It's a trick question, but vitamin K will fix it tomorrow. Now that will work, but it's going to fix it in one day. Okay, what's the fancy word for vitamin K? Because vitamin K is the brand name. It's called phytonadione, right? So that's what your reversal agents are. All right, so we try to fix the reversals if we can. FFP does not really raise volume that much. It might bump it a little bit, but they used to give it all the time to try to raise volume, but albumin is usually the better derivative. Okay, it must be thawed. It's frozen, so there's no like preservative in it because it's not blood. It's not going to coagulate. It's frozen in a deep freezer somewhere, and when you need it, then it's going to be thawed. It takes about 20 or 30 minutes. All right. So when you're the RN and the doctor orders FFP stat, you're going to call down a blood bank. Hey, give my FFP and my FFP. It's like, hold your horses. I got to warm it up, right? It involves this guy with really hot breath, right? So it has to be warmed up. Okay. And what about ABO incompatibility? Yes, it can happen because you're giving antibodies to someone. You have to make sure, hey, I'm giving this unit of antibodies here. So there's a unit of AB, right? Let's say it's AB negative. What antibodies do they have? If it's AB negative, they have they could have RH, right? They could have RH. So I'll be giving AB negative blood to, I'll be giving AB negative FFP to who? And give it to anybody who's negative, all right? Why anybody who's negative? Because it has no anti-A and no anti-B, right? So anybody who's negative means they could have anti-RH, right? So that's fine to give. If they're RH positive, can I give this blood? No, or this blood product, I should say, because this might have anti-RH in it. We don't know. We don't want to give it to someone who has positivity. Okay. So indications, mass transfusions, as I mentioned, it's 1 to 1 to 1, 1 platelet, 1 RBC, 1 FFP. And so, but definitely after 4 PRBCs. You give 4 packed RBCs, right? You're just giving the RBCs. Let's give some of the plasma as well. And active bleeding mentioned, and then what else? Elevated INR. To correct that, we can do that as well. Right? We don't, because if the INR is still high, they can bleed more. Right? And we have derivatives. We mentioned PCC is a derivative. Cryo is a derivative. We give that for DIC. We have specific coag factors we mentioned for like hemophilias. And then albumin. Albumin is given for a specific for volume expansion. Okay. It used to be given just for blood pressure, but it's no better than normal saline, which is super cheap. Albumin costs about $200 to $400 a bottle. Okay. So the MD orders to get the INR less than 1.5. That's literally impossible. That cannot happen. Right. So albumin. Okay, so albumin is a derivative of FFP, and it's about 40 times stronger, 40 to 70 times stronger than sodium. So it's really going to pull water into the intravascular, extravascular space. Intravascular, it's going into the vascular space, right? So it's still done for volume resuscitation. That means when someone's blood pressure is low, you want to give them more volume, we'll give them albumin. It's just more pricey, right? And then we got, if someone's albumin level is low, someone says, oh, if albumin level is low, let's give me albumin. That'll work. That works, right? It doesn't work, right? The albumin you're giving them is not functional to do what albumin is designed to do. You have to make albumin the hard way, which is via the liver. The liver makes prealbumin, and that then gets formed into albumin to do its albumin kind of things, right? So if someone's prealbumin is low, we can say, well, how do you fix someone's prealbumin? You give them more protein, right, to make the prealbumin. So there's a diet thing. That's a way to see if someone's malnourished or not, is that they're prealbumin, right? But you don't give albumin to fix low albumin levels, all right? So indication when does albumin is a given. We'll talk about this more with Med-Surg 2, but liver disease is a good reason, because liver disease, they stop making things. And one of those things they make is albumin. But it's not to replace the albumin, it's to do what albumin is designed for, which is to pull fluids, right? Someone has a huge belly full of fluid, we can give albumin to pull that fluid out of the belly, right? So diuretics, sometimes they do this, but there's like no evidence it works, where they give a albumin first, right? Pulls all the fluid in, and then you give a diuretic to push all the fluid, to pee all the fluid out. It's like a 1-2 punch. It's like, whoops, right? And it's a cool idea, but it doesn't work, right? And then plasmapheresis is something that's where you replace all the patient's plasma, right? You take all the patient's plasma away. You can't just give back all RBCs. That's going to be a problem. So we give back RBCs and albumin, right? You're giving like 8 to 10 glasses of albumin. It's a huge, that whole procedure takes about 4 hours. You take all the blood out of them, and you filter out the plasma, mix in albumin, and give it back to them. Okay. So the procedure with albumin, there's no reason to check ABO compatibility because you're not giving cells, and you filtered out the antibodies that were in the FFP. All right, it's been processed as well. It's ordered as a percentage, not a volume. You don't give like 500 cc's of albumin. You give like 1 dose of 5% or 1 dose of 25%. So that's 25 grams per 100 cc's, right? And then it's very, very thick. All right, it's extremely thick. It's really hard to administer. So it takes like 20 minutes, if you give it by piggyback, for it to equilibrate in this line before you actually get to the pump. The pump's going to try to suck all that albumin in, but it's going to start drawing air, and you get air errors, right, from your pump. So we have to do what? We have to pop this guy open, right? That's going to help it flow, but still take about 20 minutes to flow. So usually we give it by gravity if we need to. Okay, so you must open that IV chamber, and albumin's given via glass, so we know that all glass chambers need to be opened up, right? What else? What I have here. So anyway, most open IV, you must open the IV chamber, and this is all glass IVs, right? So albumin is super, thick as oatmeal. Okay, so albumin also, this is an example of plasmapheresis, where you take the patient's plasma, that's taken out, and you replace it with albumin.
Says human albumin, we give non-human albumin.
Is there such thing as non-human albumin? I don't think so, because that's also playing with science. No, we do a lot of pig stuff, but that's not. We don't do pig albumin just yet that I'm aware of. Okay, so MTP. So we'll do MTP, and I think then we'll take a quick break and come back with the procedure and complications. Right. So MTP is where you're giving all three: FFP, platelets, and RBCs, right? Even all three of those. And it's usually a 1-to-1-to-1, but unfortunately we have blood shortages. So that's not always a possibility, right? So sometimes we'll compromise and say 4-to-2-to-1. So 4 PRBCs, 2 FFP, and 1 platelet. And for 1 platelet, you need to have this from 4 to 6 people. So it's going to take a second, right? All right, so massively bleeding patients, like they're bleeding out in front of you, they're vomiting blood, or they are like hemorrhaging. We need to give just O-negative blood. That's usually what's given with MTPs. And once the 20 minutes has elapsed and the blood bank has finally identified what blood product they are, then that's when we can give type-specific blood. Okay, and when we give blood, it comes from a refrigerator, right? When we give FFP, it came from a freezer. It took 20, 30 minutes to thaw. But when you give blood, it's cold. And what's wrong with coldness? It might cause constriction, but what else? It's part of that triad, that deadly triad of acidosis, coldness, right? And coagulopathy. You're going to get coagulopathic when you start bleeding too much. You bleed out all your coag factors. But acidosis and coldness inhibit platelet function. They can't work, right? So we want to make sure that we give someone warmed blood, right? Not cold blood, especially if you're giving a lot of it. If you're getting just one unit of cold blood, it's going to be icy, watch out, right? But otherwise, it's just like when you get the wipes, it's like it's going to be cold, right? So then, but if you're getting like 4 units, 8 units, 12 units, sometimes when you're doing these massive transfusions, it's like it's a whole, like for an hour, you're transfusing a whole bunch of blood to the patient, okay? So you want to make sure that is warmed. We give it through a blood warmer. We have a special device. I thought maybe it's on the next slide. We give it a special device that will give it nice and warm and nice and fast. It'll warm the blood and give it fast. Okay. So IV access. We want to make sure that we aren't giving them blood that's getting hemolyzed on the way in. So the catheter size needs to be adequate, which is usually 20 gauge or higher. So I should say higher, 20 gauge or bigger. Okay, or better, right? Is a good way to say that as well. NTP complications. You're giving 4 units of blood. That's 4 units of preservative. So that's a way to get what? Hypo or hyperkalemic or hypercalcemic? Hypocalcemic, right? If I hemolyze that blood, that's going to put them at risk for hypo. Which one of those 4? Hyperkalemia, because there's potassium inside of every living cell, right? Also, we check to make sure it's not expired. That's a good reason for it to hemolyze. Another reason for it to hemolyze would be if they have the wrong size catheter. The third way for it to hemolyze is if we give it via the wrong what? The wrong fluids, right? So with NS, it's not going to shrink the cell. It's not going to make the cell blow up, right? So we'll talk about that. We'll talk about the administration, okay? So hypocalcemia, we want to avoid by checking the calcium level. So we check it usually after 4 units of blood. We'll check the calcium level. And then hyperkalemia, you got old RBCs or expired RBCs, and also we give NS. LR's on the to-do list. It's been used since like 2015, but it's not like an official recommendation just yet. Okay, and make sure the INR is good. So we're making sure when we're giving all this massive transfusion, we're checking to see are they still bleeding, right? That we can visualize that, but is the hemoglobin stabilizing? Is the platelet count stabilizing? Is the coagulation stabilizing? Because again, you bleed out platelets, plasma, and blood, and you bleed out all those little proteins such as coag factors. So those can keep bleeding out, and that can be an issue. Okay.